Welcome back. In this presentation, we're going to review AFib and acute coronary syndromes, and particularly with a focus on AFib and some guidelines that were published in January of 2024. Not a lot of the guidelines have changed substantially over the last few years with AFib, but they've all been consolidated to a new set of guidelines that are pretty thorough. I'm going to, even though there are a lot of slides in this set, I'm going to try to go through them a bit efficiently with you. So to improve that efficiency, I've relegated slides into four categories. One is a key slide that's critical, I think, for you to stop with that slide and try to get the sense of more or less everything that's on that slide. That slide might represent a major concept or set of concepts or principles. There then is a lower grade of importance, but still important slides, with the second slide with a shooting star on it that's important. And those are important for you to make sure you understand virtually everything on that slide too. The third set of slides don't have any mark on them at all. And those are sort of the standard slides where you should try to get the gist of the major concepts that are on those slides, but not spend too much time focusing on that. And then the fourth set of slides are those that, at least for this curriculum right now, makes the most sense for you not to focus on. Just breeze through, get a sense of what the 30,000-foot view is with that, and know that if that issue were to come up in your practice, there are places you can go to find that, or that might be an issue that is more for the specialist than it is for you. Okay, so let's get ourselves started here. First are the objectives. These sort of overlap with the objectives for the antithrombotics, and so important to recognize that the antithrombotics are a major part of these, but not the only part of these guidelines. And also we'll have you focus on atrial fibrillation and acute coronary syndromes and match this with what you're hearing in ClinMed. So these guidelines that were published January 2nd of 2024 were developed late in 2023 in conjunction with most of the major organizations that kind of review cardiovascular guidelines, the two major ones being the American College of Cardiology and the American Heart Association. And they looked at guidelines for both the diagnosis and management of AFib, and I think it's important that we kind of look through these sets of guidelines. You're probably familiar with guidelines by this point in the curriculum, even if it's you're not that far into it or you are far into it. But recognizing that most sets of guidelines will categorize their recommendations based on strengths class 1, 2A, 2B, 3, and 3 avoiding because of strong harm, and using this color code system. And then the darker the blue is, levels A, B, R, B, NR, C, LD, and CED. The lighter the blue is, the less evidence there is to support that recommendation. And the darker the blue is, the stronger the levels of evidence are. So as you look at recommendations, keep in mind how strong that recommendation or consideration is. And finally, as sort of a preliminary here before we go through this, there are lots of abbreviations using these guidelines. We've also posted these full sets of guidelines online for you to access, but the abbreviation tables are also cut and pasted here. So all I did with this basically for the AFib guidelines is I just cut and pasted selected key images, slides, tables, figures that represent major principles to go through it. But there's more in-depth in the guidelines themselves, and if there's a question or concern, I'd encourage you to go pick through those more detailed guidelines as posted by the AHA and the ACC. So here's the first of many slides here. This just reviews the stages of the evolution of atrial fib progression from folks who are at risk to AFib all the way to folks who have really permanent continuous AFib and sort of the ranges among those. So important as you look at AFib in ClinMed, this may be helpful in the context of where is that person in the relation to their risk profile or their stage of AFib. The key management principles of AFib involve looking at the foundation we've got for looking at what people's risk factors are and to treat those cardiovascular risk factors. And we've heard of these throughout cardiovascular medicine, but a lot of these also are related to endocrine health and other situations as well. So tobacco cessation, obesity management, limited ethanol, appropriate sleep and sleep hygiene, evaluating heart failure as a comorbidity that's concerning for AFib and risk for AFib, folks who have adequate exercise, folks who have atrial hypertension, and folks who have diabetes. So really managing all those factors in and of themselves. And another key principle is shared decision making. There's a lot of things that are going to come into play that the patient and or their caregivers or family or loved ones may have some input in as to helping assess the risk and the benefit of each modality. And then the three sort of major pillars are to reduce stroke risk by assessing what that risk is, quantifying it the best way you can, and then managing that stroke risk. To optimize all of the modifiable risk factors, both below here and other things that contribute to AFib, and then to manage symptoms, including AFib, the burden of AFib, and the decision about whether you would go with rate versus rhythm control. You want to consider all of these factors, and they really go hand in hand. So as you go through this, you'll sort of see us focus on the anticoagulation and stroke risk portion, or you may see us focus on rate or rhythm control or other risk factors that affect AFib, but all of them are important, so you have a consideration for that. As you look through mechanisms that lead to AFib, this is a very busy slide, but just know it's not just one factor, but multiple factors. The renin-angiotensin-aldosterone system activation has a key role here, but also all of the other sort of comorbid or condition states like sleep disorders, particularly sleep apnea, obesity, alcohol abuse, all play oxidative stress, pre-existing coronary artery disease. All of those play roles in the risk of developing a progression to AFib. When you're assessing someone with AFib, the guidelines are recommending a consideration for whose might be at higher risk for AFib. So this CHEST guideline or C2HEST chest guideline look at risk factors that predispose to AFib, including coronary artery disease and or COPD. So each alone has 1 point and the combination of them has 2. Hypertension, age over 75, systolic heart failure, and thyroid disease each get their specific points as it's listed here. There's lots of these types of tables with recommendations focusing on certain principles. One here is the role of primary prevention, and all of the things that are sort of foundational for reducing the risk for AFib are listed here, including managing obesity, physical inactivity, alcohol consumption in excess, smoking cessation, glycemic and diabetes management, hypertension. All of those are sort of standalone in a sense, but contribute to AFib risk, and so are done and managed in conjunction with AFib. And as we'll talk through this block, it'll become clear that some of the very therapies we use in some of those arenas are also helpful in AFib as well. Weight loss certainly is a strong recommendation for folks who have a BMI over 27. There's been a lot of consternation about even using the term BMI in the last 2 or 3 years. But even though there's a concern about whether we want to consider the whole issue of weight, overweight, or obesity as a construct as it relates to cardiovascular risk, BMI is still probably about the best thing we have, but we don't hang too much of our hat just on that alone. The other issues are with the availability now of particularly GLP-1s and what role they are taking in obesity management or overweight management. Those are pretty much standalone therapies as well, and those are discussed elsewhere in the curriculum. Physical fitness important, so moderate to vigorous exercise with an estimated 210 minutes per week is recommended to reduce symptoms of AFib and burden. That's not something you start right away for folks who are deconditioned, but certainly work your way toward as a goal. Smoking cessation, important in AFib, a very strong recommendation. Reasonable alcohol consumption, also an important consideration. In these guidelines, this one surprised me. There really is no benefit for asking people who are caffeine drinkers in general to abstain from caffeine. So you would think that caffeine would be correlated with the risk for AFib, but as long as patients don't have direct symptoms where caffeine is known to directly trigger their AFib, in general, as a general recommendation, caffeine restrictions are not really considered a recommendation at all. In fact, they offer the caffeine reduction or cessation entirely doesn't cause any benefit. Doesn't cause harm, but it doesn't cause benefit. Important to treat hypertension. We've talked about that, but the hypertension as a risk for AFib is also a consideration. Important to look at folks who might have sleep apnea, particularly sleep apnea that may be correlated with AFib. So getting appropriate sleep evaluations for individuals who are at risk for sleep apnea or obstructive sleep apnea is important, and then manage that with whatever management strategies are appropriate for that degree of sleep apnea. Having a comprehensive care plan important, and I think this is just basic medicine, good medicine all along, but to look at comprehensive care with everything in their conditions, not just looking at their AFib alone. So the three models are the CHADVAS scoring system, which had an earlier version about 14, 15 years ago, and then got updated in the middle of the last decade, almost 10 years ago, to include a few more elements. And the elements they include are age over 75 or age 65 to 75 getting points, females, hypertension, diabetes risk, congestive heart failure risk, a prior CVA or TIA, known vascular disease, and then sort of considering based on the scores, a 0 score is considered low risk, a score of 1 is a moderate risk, and scores over 2 are higher risk. But those are triaged in a sense that I think in most of our minds as clinicians, someone who had a prior TIA or thromboembolic stroke who presents with AFib is probably at much higher risk for another TIA or stroke with their AFib, unless you look at managing that AFib with anticoagulation or getting them into normal sinus rhythm. So as you look at these scoring tools, I think you'll find that they are helpful, but they are not absolute, and you're looking at the context of the patient in front of you. There are two other scoring tools. I don't have a lot of familiarity with these, but other clinicians may, and you may hear about them. One is Atria, and the other is called a Garfield, where there is a point value system for some of the same elements, and then some of these include elements that are or aren't included in the CHADVAS scoring system. The published studies related these are listed. The older CHADVAS scoring tool has been around for a long time, and the updated one I guess I misspoke a minute ago, is actually 15 years old in 2010. But these other tools are sort of available as well, and the guidelines sort of point to where you might find those if you're interested. But I think most folks still use the CHADVASC scoring system. The scoring tool here, and I've made this sort of the major concern for you, is you should be familiar with CHADVASC scoring and each of these elements, how many points they are. And what I find most clinicians will, or many clinicians will do, is when they are diagnosing and managing AFib, right in the note, they indicate what the CHADVASC score is for that patient. And that helps fellow clinicians understand the degree to which that patient has a thromboembolic risk associated with their AFib, and how aggressively or how important it is for that patient to be anticoagulated. And if there needs to be an interruption in that anticoagulation, the duration of that interruption might be influenced by the CHADVASC scoring tool. So the CHADVASC is helpful for clinicians to assess what's their thromboembolic risk and how do we manage the antithrombotic therapy with them. Here's the CHADVASC scoring tools again that are listed here in a more simplified table. And it gives you sort of an adjusted rate year of what the rates of stroke might be for people with certain scores. And as you look through these, you'll see that over the course of a year, patients with a score of 0-1 have a pretty low potential for a thromboembolic event. But as the number of scores get higher, 2% or higher per year, there's a more compelling reason, the higher you go, to anticoagulate that patient. So we used to have a different set of guidelines where we would give or recommend aspirin or antiplatelet therapy for patients who were intermediate with a CHADVASC score of 1 or maybe 2. And the newer guidelines address that that's really doesn't make a lot of sense, and we don't really do that much anymore. So what you'll find really is that the guidelines pretty much say if you're 0, you probably don't need anticoagulation. If you're 2 or higher, and some people would say if you're a male 2 and if you're a female 3 higher, you are candidates for antithrombotic therapy, and usually that's with a direct-acting oral anticoagulant. Usually it's apixaban or rivaroxaban. For the folks who are between 1 and 2 listed here, those are folks for whom you're weighing the risk and the benefit of bleed versus clot. So those folks still have a likely annual percentage under 2, and it's reasonable to elect with shared decision-making not to treat. And I will share with you that there are circumstances we'll see patients who have a CHADVASC score of 2, 3, sometimes even 4, for whom we elect not to anticoagulate because their bleeding risk is so very high. And so those might be folks who have had a history of an intracranial hemorrhage, or they've had some other thing, and you may want to be considering the alternatives to anticoagulation, whether you were considering something like an indwelling Greenfield filter or something else as an alternative to anticoagulation. But this CHADVASC scoring tool, again, is important for you to get your hands around. As you weigh the risk for clotting with the CHADVASC scoring in AFib, there's also a consideration of trying to consider what the bleed risk is. And this is a tool that's been around for quite a while, for 15 years, called the has-bled scoring tool. This is not by any means a perfect tool, but it helps clinicians, particularly early in their practice, to pay some attention to what are the things that are going to be associated with bleeding risk for patients. And so, like the CHADVASC scoring tool, the has-bled scoring tool has you score certain elements. Here are those elements. If you have hypertension, renal disease, liver disease, a history of stroke, prior major bleeding, an INR that's up and down a lot, and that's mostly for patients on warfarin or Coumadin, older patients over 65, medication usage that predispose to bleeding like concurrent antiplatelets or NSAIDs, and heavier alcohol intake. Now, what you look at this for the Hasbled score, they tell you about the consideration for what the percent risk might be for a major bleed in the coming year. You weigh that against the risk for a stroke. And keep in mind that some of the very elements that are in the bleed score are also in the CHA2DS2-VASc score. So, you kind of think you're darned if you do and darned if you don't. But the issue in many cases is, with the exception maybe of an intracranial hemorrhage, many other bleeds can be managed, whereas a full-blown thromboembolic stroke is often a major morbidity event, sometimes a mortality event for patients for whom they may not recover from that. So whereas many times you can manage the bleed and there might be a full recovery for it, that with the exception maybe of an intracranial bleed. So again, as you look at the Hasbled scoring tool, get a sense of it, but don't sort of hang your hat totally on it. Okay? So far we have gone through a number of framework issues to think about with AFib. In the next block, we're going to start to go through in more depth about, the interventions in AFib, the anticoagulation, the rate versus rhythm control. So we'll start that with the next slide. As we've alluded to, antithrombotic therapy is going to be a mainstay of patients who are at high risk, meaning 2% or higher risk per year of a stroke with ongoing AFib. And those patients are likely going to be candidates for antithrombotic therapy. The first recommendation here looks at for every patient or nearly every patient who has a CHA2DS2-VASc score of greater than 2 for men or greater than 3 for women, are considered candidates for anticoagulation to prevent stroke and systemic thromboembolic events. And that therapy is usually going to be with a DOAC. While you could use warfarin, DOACs, particularly apixaban and rivaroxaban, have a better track record for outcomes that both prevent strokes and lower risk for bleeds, many less interactions, easier to manage. The downside to DOACs is that they're often more expensive, particularly more expensive than warfarin, at least for drug acquisition cost. But because these are a standard of care, most insurers now cover them quite well because they are recommended strongly in these guidelines to utilize them as first-line therapy in AFib. So it is going to be the infrequent situation these days where you see somebody start on warfarin for AFib, and it's really only going to be starting on warfarin for AFib. In the majority of those limited patients are going to be folks who have another indication for warfarin, like a mechanical heart valve, where there's less data right now for the DOACs. But you will also see a fair number of patients still who have started on warfarin, managed quite well on warfarin, knock on wood, over time, and want to continue on it. And so you'll have a few folks in your settings who have sort of, in a sense, kept on warfarin because they started on it years earlier. Okay. The other considerations you want to look through here are being careful about not looking at antiplatelet therapy. In fact, concurrent antiplatelet therapy typically is considered harm or greater risk for bleeding. So important to consider that. And similarly, the addition of aspirin to reduce thromboembolic events doesn't offer any benefit and may actually increase risk. This is a fairly busy slide, but it pretty much looks at the thromboembolic rates related to each of the scoring tools and what their point value systems were. So, in summary, for patients who have AFib, this is sort of the great majority of patients that you will have who have AFib. You're going to make an assessment of their risk for thromboembolic event. And if the risk is 2% or greater per year, then they're going to be, in general, a recommended candidate for anticoagulation therapy. If their risk for thromboembolic event falls between 1 and 2%, that's considered a shared decision making decision about risk versus benefit, and you talk through with the patient about their cardiovascular risk, the risk for bleed, the risk for stroke, and the like. The choices of anticoagulants are virtually always DOACs, with the exception of situations where warfarin is first line, and that's limited to mechanical valves or mitral stenosis. Okay, not using aspirin concurrently, and not using other antiplatelets as well. So important slide here. That's quite basic. That's a foundational consideration for folks on AFib. Other considerations they have listed with patients who are on AFib. With DOACs, you want to look for drug interactions, so you're always looking for that. Bleeding risk for warfarin. If you use warfarin, the goal INR is between 2 and 3. You're watching dietary vitamin K. You're looking at routine INR monitoring. You're looking at drug interactions. And warfarin is a pretty cumbersome drug to use. So even though we don't see it that much, I would encourage, when you get to your clinical rotations, when you see patients on warfarin, have some degree of investment in trying to follow and understand what the guidelines for that are. Are they seen by an anticoag clinic that manages their warfarin or not? Okay. And then for patients who have AFib, you want to be careful about managing their risk based on not evidence-based doses of DOACs. So you really want to follow the dosing guidelines for DOACs, because you can run into problems with bleeding risk or thromboembolic events if you don't dose them correctly. And the DOACs, is relatively easy as they are, there are many variables that affect dosing of a DOAC. So you need to pay attention to all those criteria. So these slides consider some of them, and the two agents we're going to spend most of the time is with our rivaroxaban or apixaban, but you should also understand warfarin. Nobody uses dabigatran anymore. I wouldn't worry about that. And edoxaban, I think, is more a European drug than in the States. So I would focus mostly on rivaroxaban and apixaban, and also have familiarity with warfarin. You don't have to memorize this chart, but what I do want you to do is to go through it and recognize that there are some key things to think about here. So let's spend some time first with warfarin, and then I'll come back and do the same thing for the DOACs. With warfarin, there are lots of drug interactions related to drug metabolism, so you have to pay attention to concurrent drugs when you start them or stop them. You do worry about a very long half-life and the fact that these drugs are affecting the survival or synthesis of new clotting factors, not survival, but they're affecting synthesis of new clotting factors. So there's a big delay in the onset and offset of action, which has a major consideration in its use. Other considerations for warfarin here, the dose is adjusted based on INR, and that means you are constantly chasing that, particularly if there are interactions on board or changes in dietary vitamin K. You often have to adjust the dose based on drug interactions. That can be sometimes pretty significant and means pretty frequent INR monitoring. As you look at the warfarin as it relates to liver disease, there's not any specific recommendations for dosing changes or use in patients with liver disease, but you still have to worry about the degree to which concurrent liver disease affects clotting and bleeding risk, and more about that in the GI block. All right, let's go back to these same slides, but now focus on the factor 10A inhibitors, rivaroxaban and apixaban. Like warfarin, there are drug interactions with the cytochrome P450 enzyme systems, although less problematic than with warfarin. There are, however, some P-glycoprotein substrate interactions, and so there are a few drugs for which the rates of absorption via the gut and how there may or may not be transluminal transfer of the drug in and out of the gut related to these P-glycoproteins varies based on other concurrent drugs. So the bottom line is that there's a different set of drug interactions with rivaroxaban and apixaban compared to warfarin, but you still have to pay attention to them because keep in mind these oral anticoagulants have a relatively narrow therapeutic index for which there's a bleed risk and there's a clot risk. The half-lives and onset and duration of action are much shorter with both rivaroxaban and apixaban, which render these drugs much easier to manage. However, they do require dosage adjustment based on a number of things, based on indication for use, based on renal function, based on weight, based on age, and it varies by the agent. And so the doses that are listed here are the doses for AFib. But if you are using one of these agents for somebody who has a pulmonary embolism or somebody who is getting prophylaxis for VTE related to, for example, orthopedic surgery, those dosing regimens might be different than what you see listed here. So keep in mind, these are the dosing regimens for AFib only. Okay, so renal adjustment, dose adjustment with the 10A inhibitors. Other factors are drug interactions where there are certain drugs you would want to avoid or be careful about, and they relate primarily to cytochrome P450 enzyme systems or the P glycoprotein systems. And usually in your electronic medical record, there will be a flag for you if you're either ordering one of these drugs or they're ordering a separate drug that interacts with their DOAC. And so in general, there's consideration for certain drugs that affect either P glycoproteins or cytochrome P453A4 agents. And some of the examples, but not all of them, are listed here. And then finally with DOACs, for liver disease, in moderate liver disease, no dose adjustment, but we're more cautious in more advanced liver disease. There are a number of other slides included here, and many of them, while I didn't put an airplane on them, I could have. For this one, I did. These are more the kinds of issues or questions that are going to come up primarily in the cardiovascular team's office for deciding those higher risk patients who have a device-detected AFib without a previous diagnosis of AFib. And those are probably going to require more workups. There are just specific recommendations here. For patients who have who can't really tolerate an anticoagulant for whatever reason, there's the concern for or the potential for percutaneous approach to consider. For example, a greenfield filter or something else. And I defer to cardiology and ClinMed for that consideration. There are considerations, I think, that you want to always be thinking about the risk and the benefit of anticoagulation long term. So whereas long-term anticoagulation considered contraindicated, individuals who have a severe bleed due to a non-reversible cause, intracranial bleeds are always considered really serious, or other serious bleeds related to recurrent falls when the falls risk is still persistent. Long-term anticoagulation, though, might be more reasonable in certain bleeding circumstances where you can treat that bleeding concern. For example, a GI bleed. There are ways that after the patient has an upper GI bleed in particular, that we can manage that GI bleed acutely and then do some pretty aggressive things to prevent a future GI bleed. And then if bleeding is related to an isolated trauma episode and the risk for future trauma is not there, or a procedural complication of bleeding where that procedure is come and gone, those might be reasonable considerations for long-term use. So one of the dilemmas you're going to have as a clinician, and we'll talk through this in class, is the dilemma of, do I anticoagulate this person or not? What's the bleed risk? What's the clot risk? And that will, you'll get a better sense of that in your clinical year, and you'll continue to hone in that skill during your practice. And you're going to be talking with lots of clinicians. And most often that decision is made in conjunction with the patient's values, but also what is GI, what is neuro, what is cardiovascular team, what are those specialties, what do they chime in and recommend, help you with that risk assessment. Active bleeding on anticoagulants, you have to know your reversal agents. We talked about that in a sense earlier, but this reinforces that. I think it's important for you to have an appreciation for these. I wouldn't worry about dabigatran because that's not a drug you're going to see very much. But for the other factor 10A inhibitors, yes, you want to kind of know that our agents of choice are either going to be andexanet or maybe a factor for prothrombin complex concentrate. The problem, usually I'll see folks go with the Kcentra or the 4-factor prothrombin complex concentrate only because it is considerably less expensive. We're talking just a couple of $1,000s compared to tens of $1,000s for the specific antidote for apixaban. And on top of that, sometimes we just write it out if it's not an intracranial bleed because the apixaban or rivaroxaban are fairly short in their duration of action. Other factors are considering for warfarin. We typically use 4-factor prothrombin complex plus vitamin K or a combination of both of those depending on what the risks are. So here's a bit of the discussion of the two agents I think that you'd want to have familiarity with. The 4-factor PCC, which is used primarily for warfarin but could be used with the 10A inhibitors, and this agent here on the left, and dexadenet alpha, which is the quite expensive alternative that is specific for 10A therapy. But all those usually are going to have somebody, sort of a specialist, rushing in to manage that. That's probably above your level of practice. Other things that are listed here for these agents, look at their onset and duration of action and monitoring that happens with those agents. Bleeding events with DOACs are listed based on different studies, but for the most part, bleeding events with DOACs are less than they are with warfarin. Warfarin becomes usually more troublesome to manage, so just recognize that the reason why DOACs are first line is because warfarin is a much more difficult drug to manage with a higher percentage of time where the patient is either under or over anticoagulated when they're on warfarin compared to a DOAC. For patients who have AFib and intracranial hemorrhage, these are patients for whom you're always going to have a consultant guide you in the risk and the benefit. And then if they have an acute intracranial hemorrhage, then you're very aggressively addressing that. So those are usually concerns that are above your level when there's the question of intracranial hemorrhage happening. Important, I think, for you to then think of how do we manage active bleeding for all anticoagulants. So if it's minor bleeding, you just hold the anticoagulant for a period of time, get through the bleeding consideration, and then consider when you restart the anticoagulant based on the bleeding episode. This might be epistasis, nosebleeds. This could be minor other bleeding episodes that you might hold a dose, manage the bleed, and then reassess restarting the anticoagulant. For non-life-threatening bleeds, we do the same thing by holding the anticoagulant. And then, hemodialysis is only for dabigatran, and nobody does that. That's not going to happen. For life-threatening bleeding, you can forget about dabigatran. For warfarin, you're going to give four-factor PCC and IV vitamin K. And for the 10A inhibitors, four-factor PCC is almost always given. And the question of giving this $20,000 to $30,000 reversal agent is probably going to be made in the moment by neurology and or hematology and that's usually reserved to patients who might have, for example, an intracranial bleed. There's a bit more about intracranial bleeding and its mechanisms listed in this slide. I'm not going to focus on that. And then you want to think about what are the risk factors for thromboembolism versus risk for intracranial hemorrhage. And so the highest risk patients for a concurrent, for embolism, with AFib include patients with concurrent mechanical heart valve disease, rheumatic disease, a prior stroke or thromboembolic event, hypercoagulable states, including certain malignancies or genetic predispositions, or very high VAS scores above 6. So those are the folks for whom you're pretty much saying, I've got to have a pretty good reason not to anticoagulate them. The factors associated with a high risk for intracranial hemorrhage are folks who have existing pathology. Very older patients are, the older they are, the higher the risk potential is for it. If they've had micro intracranial bleeds on an MRI or any of these other sort of factors have some association with an increased risk for intracranial hemorrhage. So you're weighing sort of in this cohort, particularly if you have a prior intracranial hemorrhage or a high suspicion for one, you're really kind of weighing, do I really want to anticoagulate that person or not? So maybe their CHA2DS score is 3 or 4, but they fall high in this category. These might be people for whom you're making some decision-making with the patient, but also likely with cardiology, neurology, maybe hematology to figure out what the plan is. Okay, so important for you to have an understanding of those bleed and clot risks. The other issue I think that's important for you to have an understanding for, and it seems kind of like a minor point now, but when you're in practice, you'll realize it's not so minor at all, is when you've got a patient scheduled for a procedure, a minor or a major procedure, a minor procedure where there might be little or no risk for blood loss, a moderate or major procedure where you are expecting some blood loss, then the question comes into play, do you interrupt anticoagulation? And we see this in acute care all the time. So the decision in part rests with what's their CHA2DS score, what's their thromboembolic risk, what's their potential bleed risk, and what's the bleed risk associated with the procedure that's being done. And some surgeons or clinicians would require that anticoagulation per protocol be stopped for a certain window of time before, during, and restarted after surgery when the patient gets cleared by the surgical team. So the decision before has to do with when would you expect the offset of the drug to have its full effect. That's the advantage of the rivaroxaban and apixaban, is that usually within 12, 24, but certainly within 48 hours, the anticoagulation effect is pretty much gone after you stop the drug. So you're talking usually about omitting the drug for the 24-hour window of time before the procedure. For a more likely for high bleed risk procedures, maybe 48 hours. And the advantage that has is that it's a small window of time where the patient is not anticoagulated. So while their annual risk for a thromboembolic event is 2, 3, 4% a year, their risk for having a thromboembolic event in those 2 or 3 days is pretty low. Okay, so that might make sense. With warfarin, it's much more complicated, because with warfarin, you have to stop the warfarin 5+ days before the procedure and then transition them to a shorter acting, shorter onset agent. And if they're on warfarin, in these days, it's usually somebody who has a mechanical valve or aortic stenosis or something, a mitral stenosis, and those patients, they are often transitioned from warfarin to Lovenox. because Lovenox is the only other drug really that has a track record for managing anticoagulation in those high clot risk patients. DOACs don't have that data. And then the decision of when to restart therapy after the procedure largely rests with the surgeon or the person who conducted the procedure to kind of recognize how much invasion of vascular tissue did they have. What is their bleed risk post-procedure based on not only the type of procedure they had, but what happened in the OR. So if they nicked a vessel in the OR that they didn't expect to do, or there was a lot of blood loss in the procedure that was greater than what they expected, they may elect or recommend to hold off on restarting anticoagulation longer than the typical window. So important for you to get an idea that for peri-procedural management with AFib, because the risk for a clot is not, huge in general as it relates to, 2 to 4 days off of an anticoagulant. And with AFib, we often will stop their anticoagulant, particularly a DOAC, a day or two before the procedure, restart it up a day or two after the procedure, depending on their bleed risk. For other indications, though, for mechanical valve or mitral stenosis, or folks who have a pre-existing or concurrent thromboembolic event running, those patients may have a more compelling reason to have a shorter window without anticoagulation. And those become more complicated, but it's a little easier with AFib because with AFib, the risk for the clot is less than it is with other conditions we're using antithrombotics. There's more recommendations here about peri-procedural related to how things are done, but I think I explained the gist of it in the last slide. The timing of discontinuation depends on the agent. Typically for low-risk bleed, for the DOACs, it's a day, and for high-risk bleeds, it's 2 days. With Coumadin, as I alluded to, much longer. And then patients who, again, are undergoing procedures, this sort of outlines a flow chart for the same kind of peri-procedural consideration should have in practice. With special populations, folks who are undergoing percutaneous coronary intervention, PCI therapy, with concurrent AFib, there are certain recommendations that are listed here that for the most part we're looking at DOACs over vitamin K antagonists like warfarin, and that still stands here. And then they talk about the situation for dual antiplatelet therapy or role of aspirin around the time of their procedure. For folks who have coronary disease, chronic coronary disease, they also make recommendations for if they are beyond a year after revascularization with a stent, what's the decision making for oral anticoagulation versus oral anticoagulation in conjunction with an antiplatelet. And we'll talk more about that in acute coronary syndromes in a little bit. For peripheral vascular disease, there are some recommendations for monotherapy with oral anticoagulations is reasonable over dual antiplatelet therapy, dual therapy with anticoagulation and antiplatelet, or an anticoagulant and antiplatelet. For folks with chronic kidney disease, we alluded to this earlier, you want to consider the dose adjustment and the use based on renal function. So important to consider that, and then to make sure that each drug you're going to consider using has data for the degree of renal impairment that patient has. This chart, in fact, goes through that, and you'll really pretty much see that there are regimens across the board for the DOACs now, even in folks who have significant renal disease in AFib, based on these variables. Okay. Now, these primarily, again, are dosing regimens for AFib. They may not correlate directly with the dosing regimen for other indications for these two DOACs. For folks who have valvular heart disease, that becomes a more difficult scenario but the data is primarily warfarin or maybe Lovenox and enoxaparin have more data than the DOACs do, depending on what that particular valvular disease is. And it's particularly mitral stenosis of moderate or greater severity, and a history of AFib. These are patients who are going to be likely candidates for warfarin. They're probably already evaluated by the cardiologist. Anticoagulants and flutter is very similar to AFib, and they're listed pretty much here. And again, the guidelines for a flutter and the algorithm here looks at some of the issues we're going to talk in a bit about rate versus rhythm control, in addition to the consideration for anticoagulation and as it relates to how we manage that. Okay, we've covered the crux of the anticoagulation issues. We're going to move on to considerations for rate and rhythm control in the next few slides. All right, let's move on to rate and rhythm control. I think, as you probably are learning in ClinMed, one of the major concerns associated with AFib is the risk for thrombus on the atrial appendage, which could be released and ultimately lead to a risk for CVA. But the other risk is a rapid ventricular response that can lead to major ventricular arrhythmias. And so in general, we're going to look at, for most patients, doing rate control to keep their heart rate below 100, 110. And then many of those patients are going to also be candidates for rhythm control, either with ablation or with pharmacology, some other sort of way to get them into normal sinus rhythm. If you can get somebody pretty much continuously into normal sinus rhythm, the advantage is, if they won't go back into AFib, in and out of AFib, the advantage is going to be that you don't need to anticoagulate them, because they're, once their clot risk is considered low or minimal, then you don't have the same risk that you'd have for forming a new thrombus on the atrial appendage. So, important considerations. Rate control primarily revolves in keeping the heart rate below 100 to 110, and that usually means assessing a patient for rhythm versus rate control. Almost everybody who has a heart rate over 110 is going to be a candidate for rate control. That's pretty easy to do. We slow conduction through the AV node with one of three categories of drugs that will slow AV nodal conduction. That's either diltiazem, metoprolol, or perhaps digoxin. Those are the mainstays of rate control. The decisions, though, and when we look at rate control, is what we're going to really do is reduce acute symptoms and maybe some degree of long-term symptoms. You're going to reduce the risk for tachycardia-related cardiomyopathies, and you're going to kind of look at other options that are going to avail themselves once you get rate in rate control. Acute rate control for somebody who has a really rapid heart rate, typically we're going to look at beta blockers or non-dihydropyridines, which is really just diltiazem. Verapamil is a possibility, but no one ever uses it. But you've got to consider that their EF is above 40%, because we're going to find that particularly non-dihydropyridines like diltiazem are relatively contraindicated in heart failure, and beta blockers have to be done kind of carefully in the face of an acute patient who has a low EF in heart failure when we start a beta blocker. So we're going to be careful about that. If they have a rapid ventricular response and either beta blockers or diltiazem aren't effective, then digoxin could be a consideration, but that's not really a first-line therapy there. Other issues to think about related to acute rate control revolve around what do you do in somebody with decompensated heart failure, and there's an algorithm or chart in a bit that sort of talks about that. And if you have somebody with severe left ventricular systolic dysfunction, then you need to be particularly careful about really avoiding diltiazem And then you might want to consider, based on the goals and decompensated heart failure, about what other options you have. Maybe a beta blocker, maybe digoxin. And that understanding of our choice in heart failure will relate in part to your understanding of our principles of management of heart failure, which we cover in the third week. So, important for you to know the pharmacologic agents that are important in rate control. One of them are beta blockers. Primarily the one we'll use is metoprolol, which slows AV nodal conduction. The other two we'll use are diltiazem acutely, although not often chronically, and maybe digoxin as a backup in patients who aren't candidates for either diltiazem or metoprolol, or for which diltiazem and metoprolol hasn't really done the trick. So in hemodynamically unstable patients, those folks are directly going to go to direct current cardioversion with all of the concerns for thrombus release in being problematic. So usually concurrent anticoagulation, assessing thrombus risk. But really that might require sort of immediate decision-making with risk for thrombus. For folks, though, who are hemodynamically otherwise stable, then the next question is, do they have decompensated heart failure or not? Decompensated heart failure is not that commonplace. We'll talk more about decompensated heart failure in the third week of this block. But if they don't have decompensated heart failure, then it's either beta blockers or diltiazem, maybe the addition of digoxin. If they do have decompensated heart failure, then they might be candidates for amiodarone. They might also be candidates for digoxin in some limited degree, depending on what the decompensated status is. And they might also be candidates for mag sulfate in addition. Long-term rate control, most often I'll see folks on beta blockers or diltiazem. And if they have consistently low EFs below 40%, we are going to be avoiding diltiazem. Long-term rate control then pretty much is beta blockers or diltiazem if their EF's above 40%, or beta blockers alone if their EF is less than 40%. But they could also be candidates for digoxin as well as sort of a secondary agent. But in low ejection fractions, we avoid diltiazem. AV nodal ablation therapy gets into more specifics than we're going to talk about here. Just know that there are some guidelines here about how that's done and who's candidates for it and how you lower the risk in considering implantation pacemakers as part of that decision making. Now on to rhythm control. Rhythm control offers some clear benefits, particularly folks who have reduced left ventricular function or a high burden for their atrial fib. Rhythm control is often a strong consideration. There are lots of other considerations that the next chart will go through, the next slide will go through, differentiating pros and cons of rate versus rhythm control. So the patient factors that would favor rate control versus rhythm control are patient preference. Patient preference may prefer, okay, I'm fine with the rate control. I don't want to get shocked. I know I'm going to have long-term anticoagulant therapy if my CHA2DS2-VASc score is above 2 or 3, but they may have a preference for that. Or they may understand, look, I want to do everything you can to get me in normal sinus rhythm so that I don't have to necessarily be a candidate for long-term anticoagulants. Older patients typically don't tolerate rhythm control as well and often if they've been in AFib for a while, the rhythm control may not sort of take. They may be more likely to go back into AFib as well. The longer they've had a history of AFib, again, rate control is preferred because rhythm control may not really work. And depending on their symptom burden, the more symptoms they have, the more likely they're going to want to have rhythm versus rate control. There's other sort of findings here that are listed that are problematic as well. Rate control and heart and AFib it's often if their rate is difficult to control with rate control, then rate control has really not worked well, and they really need to consider rhythm control. Depending on also the degree to which the left atrium is, its size might affect that decision. Left ventricular function makes a difference, and the degree of AV regurg also makes some decisions there. And usually when it comes to a choice between rate or rhythm, as a clinician, you're likely going to be doing rate control immediately on everyone because you have to get their heart rate down below 100 to 110, and you can usually easily do that with diltiazem or beta blocker or maybe DIG. But rhythm control, most often this decision is going to be made in conjunction with cardiology. That cardiology is going to help you in that process for making the decision of who's a candidate for rhythm control and then how to go about that. The treatment decisions, again, have to do with heart failure risk and shared decision making. And then your choices involve either drug therapy, catheter ablation, or surgery. And each of those have their own kind of place. For the antiarrhythmic drugs, most often it's going to be one of these antiarrhythmic drugs, and very much of the time it's going to actually be maybe amiodarone or one of these other agents we'll talk about. And it kind of depends on their particular situation involved. And then catheter ablation are often first line for certain patients for whom that's what they want and maybe don't tolerate antiarrhythmics well, or folks who have failed antiarrhythmic therapy. Preventing a thromboembolism in the cardiac setting, you really need to be very up to speed and aware of this. For folks who have been in AFib for 48 hours or more, they are a high risk when you put them into cardioversion, either chemically or ablative therapy or however you do it. They are at a high risk for throwing clot. And so if you know that they've been in AFib for 40 hours or more, you need to do one of two things. You either need to have them on 3 weeks of uninterrupted anticoagulation, or you need to do a transesophageal echo, transesophageal, not transthoracic, to evaluate that you don't have an intravascular thrombus. Either of those two things have to happen before you initiate cardioversion. And then patients who are undergoing it typically will have anticoagulation established and continued for at least 4 weeks without interruption after their cardioversion takes place. So important things to sort of recognize that. The degree and duration of anticoagulation post cardioversion is going to continue partly to lower clot risk as it moves forward, but also to make sure the patient doesn't go back and remains in sinus rhythm versus goes back in and out of AFib. So that decision is often made in conjunction with cardiology. Other things for preventing thromboembolism, there are weaker recommendations here about other candidates for whom anticoagulation is maybe not being considered or not used. But you would probably consider, even if you know that somebody has only been in AFib for less than 48 hours, you may still want to consider some assessment for intracardiac thrombus, particularly if their CHA2DS2-VASc score is particularly high. And the other issue here is that how reliable are you? How likely is it that the patient has only been in AFib for 24 to 48 hours versus what is it if they really, in fact, have been in and out of AFib and you don't know that. So the issue of knowing with certainty that the patient has not been in AFib before and is now only in 48 hours or less of AFib, you don't always know that. So you probably want to err on the side of imaging in those cases. Here's an algorithm that goes through hemodynamically stable AFib who are planning for cardioversion. I encourage you to sort of walk through that to have a better understanding of how this is sequenced. For electrical cardioversion, not a focus for me in pharmacology, but is important for a clinical decision making. Do you go electrical versus do you go pharmacologically? And in both pharmacologic and electrical conversion, cardioversion, you still absolutely still need to either rule out a thrombus before you do it or have them on 3+ weeks of anticoagulation therapy. There's other guidelines here that sort of list ongoing factors related to electrical conversion. I encourage you to read through that. And more issues with pharmacologic cardioversion. And you'll see the recommendations for pharmacologic cardioversion are often less so. They've become less and less strong than using electrical cardioconversion. And the reason is that the drugs themselves are not great drugs. They are associated with lots of toxicity and adverse effects that are both short and long term. And patients often don't tolerate them very well. And so we'll talk about those drugs in a bit. But you'll notice that the pharmacologic recommendations for pharmacologic cardioversion often take a back seat to electrical. Of the drugs used pharmacologically, the one I see used the most is amiodarone. Amiodarone you need to think of as far as a drug that's given IV, often in acute arrhythmias, but even when we're loading somebody with AFib to chemically convert them, we often start with an IV loading dose and then transition them to a continuous infusion and then a maintenance dose. And amiodarone requires the front loading doses we alluded to in the antiarrhythmic block, but then a long-term, because that's such a very long half-life, that you take a while before you get to steady state. I don't very often see flecainide or ibutilide used, although they are sometimes decisions that the electrophysiologist might make for cardioconversion. Procainamide and propafenone, I don't see procainamide hardly at all. Propafenone I occasionally see. And then the issues here about the treatment algorithm for pharmacologic conversion AFib to normal sinus rhythm. Really keep in mind that amiodarone is often the agent I'll see used most often in this scenario, sometimes propafenone or flecainide as an orally chosen drug in selected patients. Usually this decision is made by the electrophysiologist. Let's look at some of the remaining elements in as it relates to the AFib guidelines. Here's some recommendations, which are really not the strongest recommendations for long-term maintenance of sinus rhythm with drug therapy. You can even see here the strongest of the recommendations are 2A recommendations, not level 1 recommendations. That's because the drugs themselves are not all that easy to manage, and the data we have for concurrent comorbidities with these drugs is also it's available, but it's not the strength of evidence that makes it an easy decision to make. Similarly, more recommendations with some issues problematically, particularly for patients who have heart failure, and the pros and cons of using specific agents as it relates to patients with concurrent heart failure. So here's the treatment algorithm for maintenance of sinus rhythm with drug therapy, and it depends in part on the degree of left ventricular function, as it does with whether or not someone has reduced ejection fraction with or without a prior MI. Inpatient initiation of antiarrhythmic therapies, we are going to do that with certain drugs. Dofetilide, sotalol, typically those require inpatient use, but most of the other drugs we often see a patient being admitted for their initiation of their antiarrhythmic drug to try to get them converted to normal sinus rhythm. Some of the drug-specific issues for maintenance of sinus rhythm with patients with AFib, amiodarone is the one I see the most often. There's some data here on that, or at least some specific therapy issues there. Not a focus for all this detail. And then the other agents, as we've listed here and talked about them already before. Dofetilide, again, keep in mind the major drug interactions with this drug. If you see any patients who are on dofetilide, pay close attention to drug interactions for anything else that you're ordering or taking away from their therapy, as dofetilide is one of the most significant agents for clinically significant drug interactions. Flecainide, again, a drug that we don't see used all that often. The pros and cons, as we talk about with antiarrhythmics, really flecainide use is in the domain of the electrophysiologist, as is propafenone. So the recommendation monitoring for patients who are on oral amiodarone, the frequency of monitoring is listed here, particularly focusing on thyroid function, on liver function tests, and QT prolongation risk, as well as keeping an eye on potential pulmonary complications, which are not infrequent with amiodarone therapy. There's recommendations for the other antiarrhythmic drugs as well, because we don't see them as often. I don't think that's necessarily a focus for you now. We won't focus too much on AFib cath ablation therapy. That's an issue, I think, for you as a clinician to kind of hand off probably to the cardiology service. Again, more on catheter ablation therapy. Anticoagulation before and after catheter ablation, you will be involved in this because the cardiologist may share with you what their plans are. But for folks who are undergoing catheter ablation, we want to look at what their anticoagulation status is before, during, and after, and to the extent possible, not interrupting anticoagulation around their catheter ablation, because that is a potentially higher risk for thromboembolic events. Complications of catheter ablation therapy are listed here. Again, more in the domain of the cardiologist. The role of pacemakers and ICDs are also in the domain of the cardiologist. Surgical ablation, again, cardiology is chiming in here. Managing patients who have heart failure and AFib, we touched on this. We'll touch more on this when we cover heart failure in the third week. But there are some things that you need to kind of think of that are your therapies for AFib, enhancing their cardiac function overall if they have heart failure, or are they necessarily worsening that? So we've talked in the past about drugs we would generally want to avoid versus drugs that are going to keep their AFib hopefully to normal sinus rhythm, which might improve their cardiac outputs as well. The big drugs that are considerations you're going to be careful about are folks who have low ejection fraction, and making sure that the therapies that they're having are not interfering. And probably the most concerning of the drugs that you want to avoid in AFib for patients who have reduced ejection fraction are the calcium channel blockers, particularly we think about diltiazem, avoiding diltiazem here. There's also some of the antiarrhythmics that are problematic in heart failure as well. Here's an algorithm overall for management of patients with heart failure and AFib. A more specific outline is listed here for that, with AFib primarily looking at cardioversion for if it's appropriate, and then if it's rate control, using beta blockers. If their EF is high enough, you might get by with diltiazem as well, using digoxin as a potential backup. If they go to catheter ablation, this is sort of more detail. That's really in the domain of the cardiologist. Other issues that we'll see here include genetic testing and the role of genetic testing, which is really not strong recommendations. There are specific recommendations for athletes, recommendations to consider in patients who have higher weights, particularly BMIs above 40. And we often will look at some of the anticoagulants. We actually look at varying doses based on obesity. That's true more so for the low molecular weight heparin than it is for the DOACs, but there's some evolving questionable data about DOAC dosing adjustment perhaps in obesity, but those aren't considered as a standard recommendation compared to other drugs. For Wolff, Parkinson, White, and hyper pre-excitatory syndromes, recommendations about how to manage that concurrent with AFib. For patients with congenital heart disease, there are specific recommendations related to the management of AFib as well. More on congenital heart disease. Preventing AFib after cardiac surgery, particularly if you're going to surgical practice, you want to be aware of that, but that's a focus most for surgery and the algorithm for that. Treatment of AFib after cardiac surgery, which is more common than one might think. And the management strategy is similar to what you'd see in other patients with AFib, in that you'd look at rate control and the role of whether or not rhythm control makes sense, and if so, how to do that, often with direct cardioversion, maybe in combination with antiarrhythmic drugs. Here's the algorithm for treatment of AFib after cardiac surgery. And that forks off based on whether their hemodynamic stability is intact or not. Acute medical illness and surgery, including AFib and critical care, we see this not infrequently. We often see this after non-cardiac surgery. We sometimes see it in the ICU. And we've sort of managed that in conjunction with our other comorbidities, but looking at trying to manage that AFib acutely and moderately aggressively. In patients who have hypothyroid states, we look at managing the hypothyroid state, but in addition, looking at adequate anticoagulation until the thyroid state has returned to normal and they're in sinus rhythm and they keep in sinus rhythm. So one of the dilemmas we often see is folks who have hypothyroidism and go into AFib, it may take a while to get that hypothyroid state in place, and they may be in and out of AFib more frequently. So you want to continue that anticoagulation in place until you're clearly out of the woods as far as they're going back into AFib. Concurrent pulmonary disease, there's some recommendations here, including cardioselective beta blockers are probably reasonable concerns here. We don't usually expect that if you're using metoprolol, for example, that's not absolutely contraindicated in COPD. In fact, usually it's pretty well tolerated. But if you saw an exacerbation of their COPD or their asthma, then you might want to sort of rethink that. The whole issue for pregnancy and drugs in pregnancy for the management of AFib gets a little more complicated, and I'm going to defer that to cardiology and obstetrics. There's also an additional slide that gives you some options here. And in this slide, I was frankly quite surprised to see that they had considered antenatal options with warfarin as a plan. I think what we have historically seen, really the major player has been low molecular weight heparin. I think we're still looking at what the data is for safety of warfarin and safety of the DOACs particularly as well in women who are pregnant. But there appears to be maybe some evolving data that warfarin may be not quite the risk we thought it was decades ago. That said, I would defer any anticoagulation strategy in pregnancy to cardiology and obstetrics. There are also issues for patients who are undergoing chemotherapy and or have a concurrent cancer. Keep in mind these patients are often in a hypercoagulable state, so that becomes a concern. And so anticoagulation is often even more sort of important to consider. The guidelines address that. There are also a number of cancer chemotherapeutic agents which may predispose to increased risk for AFib. And usually this is in the domain of the oncology team looking at that. But if you see a patient who has a new onset AFib who has received one of these agents, usually that's a decision made, risk benefit of continuing that therapy with oncology and evaluating the management of the AFib with cardiology. There are specific recommendations for patients who have cancer, and I think what you're always considering is their clot risk versus their bleed risk. But there are a number of issues with patients who are receiving cancer chemotherapy because of their often very common thrombocytopenia or their concurrent malignancy with bleeding risks because of that malignancy that become problematic, as well as a number of drugs that can interact with the P glycoprotein system and or cytochrome P450, particularly as that relates to the DOACs. Patients with liver disease, sort of to wrap up the AFib block, they make some vaguer guidelines here, but you're kind of careful about patients who have severe or more advanced liver disease with, for example, rivaroxaban. All right, the rest of what we'll cover is a brief look at acute coronary syndromes and the rest of sort of cardiology. Let's spend just a little time looking at acute coronary syndromes. I absolutely love this slide because it explains so much in such a simple graphic. I will talk about this also, hopefully in class, or ask some questions about it. But it's important to kind of look at the pathophysiology and the presentation of somebody with acute coronary syndromes, including stable angina, where their plaque is stable on the left-hand side. And this stable angina is also, as we discuss, associated with, somebody at rest does not have chest pain. Somebody walks up a half a flight of stairs, doesn't have chest pain. They walk up a full flight of stairs and they start to have chest pain. They sit down, the chest pain goes away. This is a plaque that has interrupted the flow of blood in a coronary vessel. So they have a diminished amount, but a measurably and kind of consistent reduction in blood flow to cardiac tissue, for which when oxygen demand increases above what the supply can be, which is somewhat predictable, they have chest pain. And that chest pain remits when they rest. That is primarily related to the fact that the plaque, while it's stable, still occludes some of the vessel and makes it difficult for blood flow to the heart tissue that vessel feeds. What becomes really concerning is when that plaque ruptures. When that atherosclerotic plaque ruptures, you see the underlining collagen get exposed, and then you start to have a platelet plug and then ultimately a clot forming a full occlusion. This can go from unstable angina to an NSTEMI to a STEMI. And the degree of that platelet-rich initial clot around the plaque because of the exposed collagen underneath that ruptured plaque leads to a partial to all the way up to a STEMI, a full occlusion. And this graph also indicates what the NSTEMI EKG looks like, with the ST segment depression versus the STEMI with the ST segment elevation. You're also looking at when you see biomarkers, particularly troponins, in not typically an unstable angina, but typically in an NSTEMI and in a STEMI. As we roll along from unstable angina on, the need to get them to the cath lab quickly is there really in all three cases, but particularly the farther along they are, the more critical it is to get them into the cath lab now. So important to look at restoring the patency of that infarcted artery to avoid significant ventricular arrhythmias and death. So critical slide, I think helpful for you to really appreciate that. Sort of the long-term standard approach to managing acute coronary syndromes as well is the old MONA with a beta blocker approach. Let's go through this quickly. Morphine is sort of pretty standard as an analgesic, and it offers some additional benefits that this slide has as well. You want to really manage the pain, but the pain also leads to a level of anxiety that increases in the pain, both increased tachycardia, and tachycardia means more oxygen demand in a situation where you're having a problem with oxygen supply. So morphine makes a lot of sense here. Oxygen as well, pretty common because you want to make sure that what blood does reach tissue is as oxygenated as possible. The role of nitroglycerin was routine years ago, and we still use it, but we kind of look at it in the context of not having people rely on nitroglycerin before they get to the emergency room in the outpatient setting. And in the inpatient setting, we usually give nitroglycerin probably as much diagnostically as we do therapeutically in the emergency department as a vasodilator to help with cardiogenic pulmonary edema as well. Aspirin, typically that's given as a chewable aspirin. The typical dose is usually 160 milligrams as a single dose, and using a clopidogrel or another antiplatelet if there's an aspirin allergy, which is actually quite rare. And then beta blockers offer a number of benefits. Beta blockers will decrease myocardial ischemia and reinfarction. They also affect slowing conduction through the AV node, which is beneficial in these cases as an antiarrhythmic. But decreasing oxygen demand is really helpful. And so the historical agent has been metoprolol. Usually it's 5 milligrams IV repeated times 2 as tolerated. Sometimes it's oral if you don't have access to IV in the setting you're in. In addition, for managing acute coronary syndromes, there are other things that are done as well. Typically, we look at ACEs or ARBs, more commonly used for trying to maintain or improve left ventricular ejection fraction because of the likelihood of ongoing heart failure post-MI. Aldosterone antagonists have a role, typically spironolactone, and that's particularly as it's related to heart failure, and we'll talk more about that in week 3. Statins are routine. We typically have folks on high-dose statins, and that's initiated for anybody who doesn't have a contraindication to them. Nitrates are considered for chest pain in a lot of cases, but they're not, they might be used in acute management for if there's a degree of ongoing refractory ischemia, but they're not routinely used. And you want to consider a nitrate-free interval if they're used beyond 18 to 24 hours. And finally, calcium channel blockers might be used when a beta blocker is not all that helpful for ischemia. So for ischemic symptoms and chest pain, where there is not a benefit from a beta blocker, a calcium channel blocker might be considered. But again, keep in mind, and we'll talk about calcium channel blockers, you generally want to avoid them for folks who have a significantly reduced ejection fraction. The cardiologists will often be involved in what's called dual antiplatelet dosing strategies, whether or not they go for a cath. And these include aspirin initially and then ongoing, and then initiating often aspirin on top of usually something like clopidogrel or one of the other antiplatelet agents. As you look at what the guidelines are, they vary. Each cath lab and each cardiologist may have sort of a different take on how they will roll this out. But when you have somebody who's going off to the cath lab, let's say you're working in the emergency department, you have somebody who has an NSTEMI or a STEMI going to the cath lab, and you want to be aware of what the protocol is going into the cath lab about what the cardiologists in the cath lab want you to do, prepping that patient getting to the cath. Now, that might be that the cardiologists themselves order these, or there's a protocol that you in the emergency department order them as you're transitioning somebody to the cath lab. Typically, it involves usually using either Plavix or one of the other antiplatelets, sometimes in conjunction with uh, aspirin or not aspirin, depending on what the protocol is. And so you want to be clear about what that receiving cath lab really wants. This is really sort of sometimes a moving target as well. There's ongoing data that evolve about the safety of antiplatelets. The one thing that I see some variation in practice is if we don't know the cytochrome P450 2C19 activity of a patient, which we often don't, and for maybe 10% of patients who have a deficiency of 2C19, they may not convert clopidogrel to its active compound. And so some cath labs prefer using one of the other agents, Brilinta, for example, in place of clopidogrel. You just want to be clear in the practice setting you're in what their practice is. There's also guidelines for the degree to which antiplatelet you use with which kind of procedure, what are they anticipated to get other therapy or not. And it's pretty rare that I see these days people use a glycoprotein 2B3A inhibitor. Those are occasionally used, and they're usually in the domain of the cath lab staff to determine who might be a candidate for that or not. Pretty rare for you in the emergency department, for example, who's handing folks off to the cath lab to have to start one of those more aggressive antiplatelets. The other issues here is you'll sort of see other 2B3A inhibitors. You want to be aware that they might be used, but keep in mind that these are not all that commonly used anymore. And again, they fall in the domain of the cath lab. The role of anticoagulants in acute coronary syndromes depends on the particular setting and are they going to PCI? What's the intervention going to be done? So the cath lab is very specific about whether they want unfractionated heparin, whether they want low molecular weight heparin, whether they want some other anticoagulant on board in addition to or in place of antiplatelet therapy. And they also know in the procedures they're doing the degree to which there is a bleed risk or potential for bleed risk in what they're going to do. So you want to really be very careful about following the antiplatelet anticoagulant guidelines that the receiving cath lab wants. Often in the cath lab, they're going to end up putting in a stent or stents in the affected vessels. And so there are guidelines that are evolving, and this is pretty old data now. This is 2018. But what's important to consider is that for the first 6 to 12 months after the stent is placed, that patient is likely going to be on antiplatelet therapy continuously and uninterrupted. That could be Plavix or clopidogrel, but it could be Brilinta or one of the other agents as well. And the duration of it between 3, 6, 12 months or beyond relates to a number of factors, which are all decisions in the domain of the cardiologist. What is important for you to know, though, and that decision is triaged by the cardiologist based on how many vessels involved, was it a drug-eluting stent or not, where was the site of that, what's the perceived risk of a reclot. But for the first 3 to 12 months after they have a stent, that's the highest window of reocclusion based on because keep in mind that as the stent's in place, the underlying atherosclerotic plaque is still kind of moving around a bit and can expose the underlying collagen, which can trigger a new clot. So antiplatelet therapy is aggressive and not to be interrupted. You will find that there will be battles between the cardiologist and a surgeon, a dentist, someone else who wants to stop the antiplatelet therapy in the window of time post-stent, where the cardiologist will say absolutely not. And so you want to really make sure that you don't stop antiplatelet therapy for someone who's had a stent, particularly in the first year after a stent, unless the cardiologist concurs with that. Be very clear about that, okay? As you look at this graph, again, don't these kind of decisions of how long therapy continues with antiplatelets relate to bleeding and clot risk. Keep in mind that these are sort of moving targets as more and more data evolve over time. Okay. Finally, as we've alluded to in the rest of this cardiology block, the updated guidelines overall, the summary guidelines for the management of patients with chronic coronary disease have been sort of updated in August of 2023. And their big findings are listed again here. Because you've heard these before, I'm going to go through this very fast, but I'll try to do it in the context of AFib or acute coronary syndromes. The levels of evidence that the AHA-ACC uses, the non-pharmacologic strategies for blood pressure management, including all the things that are pretty consistent about weight, diet, dietary sodium, dietary potassium. I'd be careful about that potassium recommendation, as we alluded to. Physical activity and moderation alcohol intake. The recommendations for weight management, pretty strong. And this is evolving now, certainly as we talk about with the glycoprotein, the GLP-1s that are available for weight management for folks. Recommendations for physical activity. Almost everybody with acute coronary syndromes is going to be sent off to cardiac rehab. And cardiac rehabilitation is great. This team really specifically looks at getting folks' physical activity up to snuff as it relates to post-coronary event in particular. They also have recommendations for tobacco cessation, which you'll see these often very similar to those in pulmonary medicine in the GOLD guidelines, for example, for patients with COPD. The resources for smoking cessation also listed here. Blood pressure management recommendations about how aggressive we're with that. And I think the issue is we're always looking at below 130/80, but there are points where you get a little more aggressive and beyond that, and certainly with certain comorbidities, we do that. When we talk about heart failure in the third week, we'll talk a bit more about how the very drugs used to treat heart failure also treat hypertension, and sometimes you're dealing actually with a lower blood pressure than that because the drugs you're using to try to improve cardiac output also reduce blood pressure beyond what these goals are. Beta blockers have a role in acute coronary syndromes as well as heart failure. We'll talk about that in heart failure in particular. We have recommendations for immunizations listed here, particularly influenza vaccine, COVID vaccine, and pneumococcal vaccine. Recommendations for SGLT2s and GLP-1s that offer cardiovascular benefit, and particularly the SGLT2s we'll talk about in heart failure, have an independent role, as well as the GLP-1s are beginning to have a role for cardiovascular benefit in people without diabetes but with weight gain. And so the role of SGLT2s and GLP-1s is going beyond the initial category or indication for type 2 diabetes. Finally, the drugs in pregnancy list here, and keeping in mind which agents are safe or safer to consider using in pregnancy. Finally, the list of drugs that I wouldn't focus too much on these, but these are drugs for which you might be expected in practice to appreciate the more common dosing used in practice. Okay, you've been very patient souls. Thank you.